All right, let's jump right in. Today, we're doing a deep dive into one of the most terrifying diagnoses out there, necrotizing fasciitis. It's a true surgical emergency, and we're going to focus in on that polymicrobial beast known as synergistic gangrene.
So, here's our roadmap. We'll start by getting a handle on just how fast this infection moves. Then, we'll talk diagnosis and identify the culprits. After that, it's all about treatment, which is a serious race against time. We'll also touch on prevention and public health, and then wrap up with complications and some clinical cases to really make it all stick.
Okay, first up, the nature of the beast. And this subtitle, Unmasking a Deceptive Killer, is not hyperbole. The biggest challenge with this disease is that it's a master of disguise in its early stages, and seeing through that disguise is absolutely everything.
So what exactly are we talking about? This is an incredibly aggressive infection that dives deep, way below the skin. It targets the subcutaneous tissue and, crucially, the fascia. This isn't just cellulitis. It spreads like wildfire, causing massive tissue death, necrosis, and gangrene. It can pop up after an injury, sure, but the truly scary part, it can also appear out of nowhere, sometimes starting from a simple strep infection.
Now listen, if you only remember one thing from this entire explainer, make it this. With a typical cellulitis, what you see is what you get. The pain matches the redness and swelling. But with necrotizing fasciitis, the patient is in excruciating, off-the-charts pain that is completely out of proportion to what you see. Their leg might just look a little swollen, but they're describing 10 out of 10 agony. That mismatch, that is your siren call. That's the red flag.
And when we say this moves fast, we mean it. The clock is ticking from hour zero. It might just start feeling like the flu, but just a few hours later, that signature, disproportionate pain kicks in. And if it's missed, well, by the time you hit the 12 or 24-hour mark, the skin starts to show the gruesome signs of what's happening underneath. Ugly purple discoloration, blisters, and then black, necrotic tissue. By then, you're already way behind the curve.
So, you suspect it. Now what? How do you confirm it and figure out what exactly you're fighting? This is where sharp clinical judgment becomes so critical.
Look, you're going to run labs. The CRP will be through the roof, the white count will be sky high. But here's the trap. Those are non-specific markers. They scream bad infection, but they don't tell you this infection. And that leads to the absolute golden rule. You cannot let anything delay a surgical consult. If you suspect this clinically, the diagnosis isn't made by a CT scan, it's made in the operating room with a scalpel.
All right, let's meet the culprits. We basically break these down into two main types. Type 2 is the one that gets all the press, the flesh-eating bacteria. That's usually one single bug, famously group A strep. But type 1, which we call synergistic gangrene, is actually more common. This is a dirty polymicrobial infection, a nasty tag team of aerobic and anaerobic bacteria all working together. Fournier's gangrene is the classic example of this.
This brings us, logically, to treatment. And there is just no other way to say this. You are in a flat-out race against time, and every single minute matters. Let me be crystal clear. Necrotizing fasciitis is a surgical emergency. Full stop. It is life-threatening on a scale of hours. If there's a delay, the patient can crater into septic shock and multi-organ failure so fast that surgery might not even be an option anymore.
The treatment strategy rests on 3 pillars, and they have to happen simultaneously. The second you think this is a possibility, step 1, call the surgeon. Step 2, the definitive therapy, get the patient to the OR for aggressive surgical debridement, cutting away all the dead infected tissue. And step 3, which you start right away, hit them with high-dose, broad-spectrum IV antibiotics. But never forget, the antibiotics are just support. The surgery is what saves them.
So what antibiotics are we talking about? If you're suspecting that type 2 group A strep, the go-to cocktail is high-dose penicillin plus clindamycin. Why clindamycin? Because it helps shut down the bacteria's toxin production. For the type 1 synergistic gangrene, with that whole mix of bugs, you need a bigger gun. A carbapenem like meropenem is a fantastic choice to cover all your bases. And in those really sick, toxic patients, you can even consider IVIG to help neutralize the toxins floating around.
Just a quick but really important note on kids. This is thankfully rare in pediatric patients, but the playbook is exactly the same. Immediate surgery, aggressive debridement, and heavy-hitting antibiotics. The only difference, and it's a huge one, is that you have to be absolutely meticulous with your weight-based dosing.
Okay, let's zoom out from the bedside for a second. How do we think about this on a larger scale? How do we contain the threat?
Well, first, from a public health standpoint, these invasive infections are notifiable diseases. We have to track them. Makes sense. Second, in the world of surgery, it's about nailing the basics. Things like pre-op antibiotic prophylaxis and keeping blood sugar under tight control. And finally, there's a great lesson to be learned from recurrent cellulitis. For those patients, aggressively managing things like chronic leg swelling with compression helps keep the skin intact, closing a potential door for bacteria to get in.
Now for the sobering reality of what happens when this disease gets a head start. We're going to talk about the devastating complications, and then we'll run through a few cases to bring it all together.
The fallout is just catastrophic. The infection can unleash a toxic shock-like syndrome that sends the patient into a spiral of hypotension and multi-organ failure. The bacteria can get into the blood and set up shop anywhere in the body. And there's a particularly terrifying complication with head and neck infections, where it can track down into the chest, something we call descending necrotizing mediastinitis. It's as bad as it sounds.
You know, everyone knows that old saying, a stitch in time saves 9. Well, in this world, that just doesn't cut it. Here, it's more like a rapid debridement saves limbs or lives. And that's no joke. That really is the bottom line.
Okay, time for a case. You've got a patient with agonizing pain in their lower leg, but when you examine them, you see next to nothing. A little bit of swelling, maybe a blush of red. What is your absolute first, most critical move?
The answer is you pick up the phone and you call a surgeon. Immediately. That is the only correct first step. This is the classic presentation. Pain that is wildly out of proportion to the physical signs is your signal to act, not to wait. Waiting for labs, waiting for imaging, that's how you lose. The priority is getting that surgeon to the bedside.
All right, case number 2. Thinking about synergistic gangrene, a classic example being Fournier's gangrene. What is the microbiological signature? What's the hallmark?
The answer is a mixed bag of bugs, both aerobic and anaerobic flora. That's where the name synergistic comes from. It's not one bad guy, it's a whole gang working together to cause destruction. This is what makes it different from the monomicrobial type 2 infections, and it's exactly why you have to start with broad-spectrum antibiotics right out of the gate.
Okay, last question. Let's boil everything we've talked about down to its absolute essence. What is the one single most critical, life-saving part of treating necrotizing fasciitis?
And the answer, without a shadow of a doubt, is aggressive surgery, debridement, and drainage. Yes, antibiotics are vital. Yes, ICU support is vital. But if you don't get in there and physically cut out the dead, dying tissue that is fueling this fire, the patient will not get better. It is the absolute non-negotiable cornerstone of therapy, and it all goes back to that early recognition. Which leaves me with one final question for you to think about. In your own clinical world, what is the biggest barrier to spotting this disease early, and what are you going to do to tear that barrier down?